Welcome to another edition of Health Matters. I'm Dr. Bruce Carlin here for WCCA and the Worcester District Medical Society, and it's my pleasure to have as my guest Dr. Don Pelto, one of our premier podiatrists, which we have many in Worcester, but he's one of my go-to guys.
Right.
Tonight we're going to talk about diabetic foot care and what you should do. Perhaps I should set this up a little bit and say what happens in my office as a primary care physician. Whenever I have a new patient with diabetes, I have to explain to them pretty carefully that that diabetes is one of these crazy diseases where the disease can take over without you really knowing it, and that the first places that manifest any of the signs of disease, even before the symptoms show up, is the foot. So we tell all our patients, you get yourself, if you've got diabetes, even if it's mild, you get yourself a diabetic foot exam and you get yourself a diabetic eye exam. And so what I thought we'd do tonight is say, all right, what are you doing that for?
What do they do when they come in the office?
Yeah, so what happens when you see a new patient for diabetes?
Great. Well, first of all, thanks for having me on the show, Dr. Carlin. I appreciate it. And when I see patients, they come in from your office or from other doctors' offices, people really want to be treated for their diabetes, but also many people come in and they've done research on their own. You're probably finding it more and more that people look on the internet and get a lot of information. And when you put in diabetes and feet, you're not going to get some very good pictures. A lot of them are concerned, am I going to lose a toe? Am I going to get a wound? What causes that? And I really start every patient by doing something called a comprehensive diabetic foot exam. And this is an exam that has a number of different parts to it. In the beginning, we look at their medical history. Most importantly, there's a number that you test, and I don't test it, but you test it, the hemoglobin A1C. I want to know how well controlled their diabetes is. If they have an elevated number, a blood sugar, that probably shows they're maybe a little bit further down the road to having a problem. If they're nice in control and at a number 6 or a 7, I'm less concerned. So first I look at their medical history, what medicines they're on, if they're already on some medicines for nerve problems, like neuropathy or other types of issues where they can have numbness and tingling in the feet. And after I do that, I really have a 4-point inspection. And I really equate it to my patients to make it easy, kind of like a car tune-up. You get your car tuned up every 3,000 miles, and just like your feet, you have to get a tune-up. And what do we look at? I look at 4 areas. First of all, I look at their circulation. And just like you can feel the pulse on your arm, you can also feel the pulse on your feet. There's 2 different pulses, and if I can feel them, that's great. If I can't feel them, or if they're barely palpable, or I can't really feel it, that might be an area of concern. We may want to see, well, what's the reason? Is there some clogging in the arteries, very similar to your heart, or what's the problem? So first I look at the circulation.
So just to get this in perspective, from my perspective, what diabetes does is the extra sugar floating in your blood. Number one, it can get measured with the hemoglobin A1C, which gives you a long-term measure of how you've been doing for the last month. But if you're getting clogs, any bed, any vascular bed can get clogged. The feet just happen to be one of the easy ones to find. And that pulse right at the top of your foot or on the back of your ankle, we often test. But I always feel that you guys do a better job of that. You're looking at other things, not just the pulse. You're looking at foot color and other things. Why don't you describe some of the other things that you look at?
Yeah, so first we do the pulse. The pulse is just the easiest way. Then I push down on the tip of the toe, and I look at how quickly the redness comes back to the toe. Or if the toe is really pale, or even red color, if there's not enough blood flowing back, that may be a problem. Another big problem could be swelling. How much swelling do they have around their ankles? And if the swelling, if there's a problem with the blood flow going back up to the heart. So the blood flow is the first area I look at.
But the swelling isn't necessarily a part of the diabetes. It's sort of what led up to the diabetes.
Exactly.
It's the people that have had a few too many meatballs that that have extra weight on and some vascular disease.
Exactly. So first I look at the blood flow. The next thing I look at is going to be the skin. And there's a lot you can look at with people with diabetes. But when you have diabetes, you're more susceptible to getting other types of skin infections because your immune response is a little bit lowered. So they may have thickened toenails, they have onychomycosis, they could have athlete's foot that goes along with it as well. They could have calluses.
So you're saying that these skin infections are part and parcel of diabetes. You're running sweeter, you don't have as much blood flow there, and so that the bacteria and fungi have an upper hand, and so when you start seeing those things, those could be signs for the patient to say, well, maybe I better check my sugars.
Exactly. There may be a concern. One of the biggest challenges is dealing with calluses. And I know everyone says, well, I get a callus because I walk too much or because I'm very athletic. But if you have diabetes and you develop a callus and that callus isn't treated, that callus can very easily go from hard skin to a blister skin. And that's where a wound, or we call an ulcer, can happen on the bottom of the foot.
So what's the difference between a corn, a callus, and a blister?
Yeah, that's a good question. If you look at as podiatrists, we always use our hand as example. If you look at your hand, on the top of the foot, that's a corn. Top of the foot or between the toes are called corns. On the bottom of the foot is called a callus. And it's just a matter of where it's at on your foot.
So where the pressure point is.
Where the pressure point is. Now, a corn or callus can be caused by tight shoes many times. A lot of times it can be caused by a lot of walking or friction. And that's the whole reason they do those diabetic shoes. I'm sure a few times you've heard about those diabetic shoes where that reduces the friction on the bottom. That's why we prescribe them. Not because everyone needs a pair of shoes, but because they've been proven to reduce the friction that can cause the calluses.
So the callus comes from
the
moving
rubbing,
around, the rubbing.
And if you don't treat a callus, a lot people maybe don't get it treated or try to treat it on their own. First of all, we don't ever recommend using a razor blade. I've heard of people doing that times because you can cut yourself. And the problem with the callus, it gets thicker and they don't feel it. And then it can blister.
Well, what do you recommend for folks, where the diabetic is not feeling his foot as well, and maybe that's why the callus is developing? Can they use like a pumice stone? What do you recommend? Or do you have to tailor to each patient?
It really depends on the patient. If you don't have any feeling, you shouldn't be using anything on your feet. If you're a very new diabetic and you have good feeling, you can use a pumice stone. But one thing I really don't ever want anyone to use, anyone that's watching this, I need to let them know, don't use anything with an acid in it. Have you heard of those corn pads people buy? They're medicated pads. They have medication. It's an acid. And the difference with the acid pad, it doesn't know the difference between hard skin and normal skin. And it can just eat away and develop a wound or a sore on the foot.
Or an ulcer.
Or an ulcer.
You see, so in other words, the difference is the callus is just the cornum layer of the skin.
It starts at the top.
It's okay. It's stuff that you can pare away.
You can pare away and treat.
But it's not the same as your skin. It's a thickened part of your skin. How do you describe that difference to patients?
I kind of explain it like a magnifying glass. If you look at a callus on the bottom of your foot, you're going to have a hard piece of skin. And that hard piece of skin actually magnifies the pressure into the center of the callus. If you don't pare away the top, that hard center is going to keep getting that pressure on top. And as it builds up and up, that pressure is going to go deeper into your skin, and eventually it's going to create a blister or a wound underneath it. In that blister, it's going to develop some fluid from the blister, and eventually it has to pop off. And once it pops off or cracks to let that pressure out, then you have a foot ulcer. That's going to be hard for you to deal with.
Especially because now you've also got less blood flow, more sugar in there. And
it doesn't hurt. The biggest problem is people with diabetes, they don't have the gift of pain. We call it a gift. you can feel when we step on something. If you drop some glass, you stepped on it, you would know, I would know. But a lot of people, they don't know. And they don't have that gift of pain. So they have a wound on their foot, and they're still walking on it. It's really challenging.
I see Rocco's playing with some of the pictures here. Maybe we can talk about them. You brought... I would point out that the pictures that you brought aren't subtle cases.
They're not. These are very severe cases. The first one that was up there was some.
Well, why don't we go with what we've got there? What are we looking at now?
So what we're looking at is a wound on the bottom of the foot. This is looking at the bottom. Those are the toes you can see at the top of the screen. And in the center, there is a wound. That's an ulcer in someone that has diabetes. But as you can see, the arch of the foot has completely collapsed. This is an end stage. This is something way along.
This is the ultimate flat foot.
The ultimate flat foot. This is someone that doesn't have any feeling. Mm-hmm. They may be walking around, and what happens is they break their foot. This is a broken foot, and they keep walking on it. The technical term is called Charcot foot, but all it is a broken foot that you keep walking on. And it creates a wound because you actually have your arches collapsed in the center, and it creates a wound that's very, very challenging to heal for us.
So how do you go about, that's sort of the ultimate and sort of worst case scenario in what happens in diabetes. But it explains a lot of the problems that you're seeing. It's the lack of sensation, the lack of the gift of pain, and
the lack of... But actually, Charcot is a little bit different. They have good blood flow. They usually have bounding pulses.
Huh.
And it's because of that good blood flow that softens the bone.
Huh.
And so the bone gets softer, it can break down easy. But we'll talk about how do you heal a wound? How is a wound healed? It doesn't matter if it's that type of a wound or just a little wound.
Just any place on your body.
Anywhere on your body. But your foot is a little different because you have to walk on your feet. It's not, you can't put it in a cast like an arm because you have to keep walking on it. When you're dealing with wound care, you have to make sure, there's only 4 reasons why wounds don't heal. Only 4. I make it nice and easy. There's a lot, but the 4 big ones.
Okay, go ahead.
The first one is due to high blood sugar or poor nutrition. If your blood sugar is very high, your skin isn't going to be able to heal. Or if you have not enough protein in your diet or not eating the right types of food. So that's the first thing. Poor blood flow. If you don't have enough plumbing to get down to that wound, you're not going to bring the healing components to heal that foot wound. So you need to have good blood flow. The third one is you could have a deeper infection. That could be an athlete's foot or an athlete's foot around it, or it even could be bone infection into the bone that you're not able to see, or a skin infection or something. Maybe it's redness, maybe it's in the x-ray you have to look at. If there's an infection, it's also not going to heal. But by far, the most important one, pressure. Walking on it. If you're walking on your foot, when you have a wound, it's not going to heal.
So what do you do about that? So now you're doing your diabetic foot exam, and you say, "Oh my goodness, we've got a break in the skin. This constitutes now an ulcer, a wound." And this guy is going to his accounting job or whatever it is. What do you do now?
It's hard. We always say it's not what you put on a wound that's important. It's not what type of cream. There's tons of different creams and medications you can put on it, but it's what you take off. So 2 things are needed. One, you have to have frequent debridement. That means where we take the hard tissue off the edges of the wound. You have to take off that hard tissue, and then you have to take the pressure off. The way we take the pressure off is with various types of shoes and boots that are modified to take the pressure off.
Rocco, do we have a picture of the boot there so that we can...
So this is an example of one of the boots that we use that people put on, and it takes the pressure off the inside. There's a little insole that you can see that's placed in the inside, and there's little pegs. And there are these little removable pegs, and you remove the pegs from where the wound is. So that as someone walks, it takes the pressure off where those pegs are at.
And so this just has multiple Velcro snaps or straps in it.
That hold it on.
That hold it on so you can put pressure every place but the wound.
But the wound.
So that's taking off in the way you were talking about it,
Yeah.
is taking off.
That's one of the easiest ways of doing it is with a boot, but some people can't wear it. It's too heavy. We can take a shoe. You can modify a shoe by doing some cutouts in them. But really the gold standard, we call it, is with a cast, something called a total contact cast. And that's where you put a cast on someone's foot, and they can that way walk on it. And that's something that's very delicate, though, because if you have no feeling and you put a cast on someone and they get a cut or it rubs, it can be a very big challenge.
Oh, how you make a cast, yeah. So let's talk a little bit more about the rest of your diabetic foot exam. I think we've cut you off a couple of times on the way to talking about it. So you check the blood flow,
the skin,
and now the skin. And so what are you looking for? You're looking for breaks in the skin. So you talked about ulcers. You're looking
dryness of the skin. Sometimes someone's neuropathy, if they have so neuropathy, it can affect the nerves, the feeling, but it also affects the skin because of the sweat glands, because the sweat glands are fed by your nervous system. And a lot of diabetics have very dry skin, and they think, oh, my skin's just so dry, why is that? Well, normally it's because of the neuropathy, and that also affects your sweat glands. So if there's a lot of dryness or cracking of the skin, we would treat that. But those are the basic aspects that we look at with the skin.
And you're also making sure that you're looking for things that people aren't aware of. So you're looking for the athlete's foot. You're looking for, and that can be a lot more extensive than people realize.
It is.
Do you want to spend a little time just talking about?
We have a picture I brought that shows the importance of it. The most important thing you can do is look between your toes and on the bottom of your foot. Why between the toes? Because it can get very, very damp between the toes, and that can create a little bit of a cut, or even in that cut can get an infection very easily. I have a lot of patients that have lost one or two toes or even their whole foot just from a little athlete's foot between their toes.
So, it's not your standard athlete's foot.
It's a standard athlete's foot.
We've got a picture here. Can you describe what we're looking at here?
So what we see here is a lot of dampness on the bottom of the foot. You see that second toe, and it got a little bit of an infection into the skin. It could also get a crack between the toes that can work its way up the foot. And someone may not feel this because of the neuropathy.
Because there's
the poor feeling. And that, if that gets infected, it could become a big problem. So whenever you notice any cracking or dampness between your toes, you should see your doctor or your foot doctor.
And try to keep it dry.
Now,
what do you standardly tell your diabetics about foot care for protecting against athlete's foot?
For general foot care, what I recommend is after you shower, you should dry well between your toes. That's important. If you can't get down there, you need someone to help you. Putting on some type of wick-away sock, whether it be a white sock is usually best because you can see if there's any cuts or any problems in the sock.
Because the sock will turn color.
It'll show the color. Also, if you have dampness between the toes, something called lamb's wool is very, very effective, and it's nice and gentle, and you can put that between the toes to dry them out. And there are different types of...
And you can leave that there.
Leave it there.
I know a lot of hikers like to use the lamb's wool and runners.
Yeah. Also, don't put your feet in the tub without checking the temperature with your hand first. A lot of people they put their toe in it, it feels fine, and they actually burn themselves. So always check the temperature with your hand and not your foot. Always check your shoes before you put them on to make sure nothing's fallen in the inside of the shoe. Very important. Putting cream on your feet is good, but don't ever put it between the toes because that can cause those cracks and dampness.
So in other words, it builds up the dampness to a point that, again, because you're not aware of things. Now, not every diabetic is going to have a neuropathy. I mean, most of them don't. I mean, most of the folks that come in, if they're early on, their A1Cs may have crept up to 7 or 8 on the initial visit, but we've got them in good control in a few months. Why should they be seeing you? How quickly do these things happen?
That's a good question, because how fast does poor blood flow or the neuropathy or these other foot problems happen? Hopefully it'll never happen in your life. I hope it never. My favorite thing all day would be to do nice, boring, comprehensive diabetic foot exams on healthy people. So they should come to see us as soon as they're diagnosed, because in the beginning, most of my work is based on education. And I focus on saying these are the 3 things we look at: poor blood flow, poor feeling, and high pressure areas. Right now, you don't have any, but we'll see you next year and just evaluate it. And so I spend the bulk of my time on just educating them.
And also telling them the various tricks that you've shared with us so far about how do you stay safe
Exactly.
Before you have the pressure. Now, do you have any other telltale signs that you say to people, come right in, this is something that needs immediate attention?
I tell all my patients to look at their feet every day. Look at the bottoms of the feet, top of the feet. And if you look at anything and see anything that's different than yesterday, give me a call and just ask me. But the most common problems I see in people that have healthy, good diabetes under control would be ingrown toenails. I see very frequently in people with diabetes, because their nail might get a little thickened and there's less room for the nail to grow in, so they have redness and pain on their toenail. That's a real common problem. I see people that they get a new pair of shoes and they wear them a lot, or they may sign up to do a walk and they walk for 2 or 3 miles when they're not used to it, and they get a blister either on the side of the foot or between the toes. Those are very common as well.
So do you give them some instructions on how to buy shoes? Well, I mean, everybody says, well, the common thing in my office is, I just spent the fortune on those sneakers. And you look at them and you say, but, they're two sizes too small. And you may have spent a fortune, but boy, was that silly.
Yeah.
What do you do in terms of telling folks about how to buy shoes?
Yeah. It's challenging, especially when you have certain people say, well, I've always been a size 6 my whole life. Whereas what we know is that your size increases over time. I'm not going to be the same size as I get older as I am now. No one is. Their shoe size always gets better. Especially women, after every child, your shoe size goes up about a half a size. That's what we tend to find. So first of all, just making it clear to them, you can't go in and just buy the shoe number, the shoe size. And also explaining that different types of shoes fit differently. A Nike versus a New Balance versus something else fits different. If they're very healthy and have diabetes, I usually send them to a local store that will actually fit their foot. And I have the Brannick device in the office where I can fit them and size them. But what I find is very beneficial through insurance companies is a lot of people with diabetes qualify for a pair of diabetic shoes through their insurance companies.
And that's not just a hoax or thing. That's really quite helpful. And you really do find that these improve the way your feet feel at the end of the day.
Because they're the right size, and most importantly, they're wide enough, and they have a little bit more depth to them. Because sometimes people have curved toes in the top, curved toe in the side that may rub their shoe and cause them pain. Also, they may not be wearing the right size, and sometimes it's a financial issue too. They need the help.
What do you do about teaching people about toenail care? I don't know. I've probably sent you a half dozen patients in the last year that just come in and they say, "Well, this just happened yesterday." The ingrown toenails grow in a hurry. What do you tell them about their care of the toenails?
For people with diabetes, and anyone in general, you should be trimming them straight across, not going down into the edge to get out an ingrown toenail. Because if you go down into the edge and you don't get everything out, there's going to be a little piece, a little wedge, and it's going to be very painful for you, and it can get infected. And even if you take an antibiotic, it'll clear the infection, but it won't cure the problem until you get that piece out.
Until there's a way for the lip to get by the lip of tissue there. Well, do you tell people to massage it?
So after I remove it, I tell them to do a massaging motion on the side of the toenail for as long as it takes till the new nail grows out. When I remove a nail, I usually remove it a little wedge of it, and then I have them pull down and have it grow out past the nail edge. But you also have to look at, why is it getting ingrown? Is it a normal nail, or is the nail a little bit thicker? If it's a little bit thicker, it could have a fungus. And I kind of equate it to wisdom teeth. You just don't have enough room in your mouth for the wisdom teeth. You don't have enough room for that nail. And that's why it gets ingrown. It's because it's thicker, it's wider, and it's more difficult to trim out. And so I see a lot of patients that just need their nails trimmed because they're too thick for them to trim, and it's dangerous for them.
Okay, and I keep thinking of more things that get sort of exciting here. On corns and calluses, now you do a lot of trimming, and right after that, a lot of patients say, well, I'm walking different. Have things gotten to beyond a point of where you've actually changed the way they walk, and why do they feel so different when you trim a corn or a callus?
When you have a corn or callus, like I mentioned before, it's kind of like a magnifying glass. The pressure under a corn is actually 60% higher than the other skin around it. So you actually have more pressure there. So it's kind of like walking on a pebble.
And so you remove the pebble.
Remove the pebble, and they can walk better.
They can, or they're back to the thing that got them into the problem in the first place. Do you often do you switch and say, look, that corn means to me that your shoe wasn't fitting right, or that does that lead to many of those discussions? Or
a lot of times when a corn, or usually a corn, if it's a corn on the top, yes, it's usually due to the shoes or the tightness of the shoes. A callus, on the other hand, is normally due to the mechanics of how they're walking. Okay. And with the callus, if the callus gets very close, we call it pre-ulcerative or close to developing an ulcer, I'll say we need to make a special insert to offload the area, meaning put the pressure somewhere else so it'll take pressure off that area of the callus.
Well, Don, I got to tell you that it's terrific. I always knew you were a good podiatrist, but you're also eloquent in describing how things go. And we're really coming to the end of another show. This has been a pleasure having you here. Maybe you come back and we'll talk about other things. You had some other exciting pictures as well.
Yeah,
we didn't get a chance to do all of them. This has been another edition of Health Matters, brought to you by WCCA-TV and the Worcester District Medical Society. Thank you for joining us. I'm Dr. Bruce Carlin, and thank you, Don Pelto, podiatrist extraordinaire.
Thank you.
It's been a good show.